So friends, hello, and good morning. Just coming back to you with a beautiful laparoscopic myomectomy. Multiple fibroids. See the beauty, the absolute beauty about this lady, and I'm telling you very honestly, okay, with her permission, okay, is that she got married in our hospital. Okay, this is amazing. I mean, something never seen something like this in my life, and never seen somebody, what a great husband she has. I really liked it, I was so happy when they got married in the hospital. I didn't know that the hospital premises can function like this as a venue for such a pious thing in life. So normally for such huge multiple fibroids which we are going to be taking out, okay, see this is one of the big ones, this is the other one, this is also pretty big. So normally for all these big ones which we want to take out, I have told you multiple times that you need to make excellent incisions, right? Your incision has to be superb. Here you go. Okay, this was the point which we discussed even with Shilpa GB when we took the master class, that make a wide incision, do not slay away from taking incisions in such situations for any of these patients. Of course friends, we will also be doing something very important, that is mapping with the ultrasound. So the ultrasound machine is on, and we will probably try to show you the mapping once we do the mapping for this particular patient. Intra-op mapping, okay. We already know there are multiple fibroids, but for the intra-op mapping we will show it to you. Big thank you to Lavkush and Santoshi for getting this thing live organized. Big thank you to Tanvi for not doing anything in the OT, because you always require one person to not do anything. That is also a very important part of being in the operation theatre. Big thank you to Golu and Praveen for assisting me. Golu is somebody whom you all know. Praveen is a very hard-working boy. Is a very hard-working boy who has joined our operation theatre team, and you will see him much more often, because Praveen and Vijay and Rasik, these three boys, are also traveling with us across the country. Okay, so you will get to see more of them in the future. And you can see no vasopressin as a rule. Where is Dr. Patil? If Dr. Patil is around, I wanted him to speak, because he has spoken on this subject so many times that I wanted him to speak one time more. If somebody can kindly request Dr. Patil to come in the operation theatre and stop looking at the market for 2 minutes, if it is fine, Dr. Patil, as you are all aware, apart from being a wonderful anesthetist, is an avid stock market investor. He has made sure that the investors in India do not feel the pinch of Mr. Jodhwala passing away. So Patil sir, if you are here,
yeah, I am here.
You are here. Praveen, sir, just a discussion, because see, we don't use vasopressin, and we had that question even in our master class, right? That why is it that we do not use vasopressin? That is one. And second, what are the sort of problems which we encounter by not using vasopressin? Now I personally think both of us together have done countless cases now without vasopressin.
But you can see this case also. No, we have not used vasopressin. You can see it in front of you.
Yeah.
But there is no need of telling that there is without vasopressin you can conduct the case. You are conducting it now.
Yeah.
And the main problem of vasopressin is because it causes lot of vasoconstriction everywhere.
Right.
And it causes problems too. We have quoted it long time that in few countries it is abandoned.
Yeah, it is banned.
So why it is banned officially? Because it causes some heart problems. There are n number of cases, not n number. There are cases of amputation of limbs and all.
Yeah.
Because of this vasoconstriction and arterial constriction and stopping of the blood flow to the organ or to the foot or to the hand. So that's the reason they stopped using it and it is banned. So something which is banned somewhere abroad. So here also, it doesn't have separate action here also, no? So that's the reason since beginning, many years now, since our old hospital, we are not using vasopressin and we hardly see any problems. Actually, you can see the case in front of you. This is not the theoretical discussion, we are having a practical demonstration in front of you.
But is there any specific things which you would...
Cases, no?
Correct.
So there will be less bleeding.
That is true. That is
And the operation, forget about bleeding also, even the operative field becomes little better also, no? See here also the BP usually we are keeping it around 90 actually systolic.
Acha.
Yeah. So we use different manuals for that. We use fentanyl usually here.
Okay. Sir, I was asking and speaking to Arun sir yesterday, he was on our live and we did have a discussion about post-operative pain relief in the form of multimodal analgesia, correct? So, just wanted to know your thoughts.
No, what Arun said actually.
No, he said about, multimodal analgesia in the OT.
Multimodal means actually we use different types of drugs. One is actually one of the best thing is giving spinal or epidural with GA. That
Right.
is one of the best things. If epidural is put, actually that can be used as post-op analgesia also.
Correct.
Usually here most of the cases we don't use that, basically because about 95% of patients are discharged next day.
That's true, sir.
So that's the reason personally I am not using much of this combination now. Since many days rather we stopped doing that. Initially I also used to do that. Now actually multimodal rather multimodal like giving tap block and all. Again I use multi-drug analgesia. We use all the three combinations of analgesics we use narcotic analgesic, that is fentanyl, which actually helps for reducing the BP also, because the other narcotic analgesics most of the time Fortwin always increases the BP. But we use Fortwin 90% cases we see always there is an increase in BP.
So there is fentanyl, one more, apologies Patil sir. There is one more posterior fibroid which we identified here on our mapping, and I will want to remove that. So I think this has been a great addition to our surgical unit, intraoperative ultrasound. Very fast, very quickly we are able to knock out a lot of these small fibroids, and almost always we have good amount of clarity and surety when we are doing that, and I think that is very important from the patient perspective. So here we go, that is that small fibroid there which we just mapped, and of course it's a little subserous component is involved, and we will just remove it out.
So discussing about the analgesia part intraop, can I speak?
Yeah, please sir, sorry.
No problem. So about discussion about this intraop analgesia, personally I don't use much of the other things. Nowadays I stop personally giving because there is no control over blood pressure and all when we give epidural and or spinal long acting and GA. It's very difficult to control the other things actually.
For example,
and then
sir, could you
could means actually this spinal, if you give spinal will cause hypotension, and in addition I give GA, then there will be tremendous hypotension and I don't have any control over that much.
Okay.
And then we finish the surgery is much faster actually. That's the reason now we have realized that there is no much use of that. And here also we give all number of patients we try to give Arcamin pre-op also. Personally I love that drug.
Yeah, sir,
Pre-op
I wanted to
Arcamin.
mention a little bit about that. Because I've seen you using it extensively.
Yeah.
I've seen a lot of other anesthesia colleagues who are coming to our unit. They don't believe in using it. So what?
No, I personally feel that is one of the wonderful drugs. Most
Okay.
the cheapest one, the tablet available.
Okay.
You give that pre-op and it causes, except postural hypotension, which is the complication of this drug, clonion.
That is because it is centrally
Clonidine.
acting.
Yeah, it is clonidine. Yeah, it is.
is clonidine,
Yeah, it is clonidine. So actually, it reduces the pulse rate and it is the best, according to me, cheapest one oral tablet about 1 hour or half an hour earlier before pre-op, and it was wonderful, especially whatever the BP rise is there because of carbon dioxide, it is always controlled with that. That
Right.
is what my belief, and I always I'm happy using that. If I don't use that, I use Clonion. Like this patient, we took it suddenly, though we
Right.
did not have time to give tablet Arcamin, so we are using Clonion. Personally, I use that.
45.
Then again, talking about the analgesia part, we give Dynapar. Actually, I give that intraop,
Yeah.
and then at the end of the surgery, I use paracetamol, that IV Pacimol, and like whenever I do the cases, I hardly give it tab blocks also, hardly,
Yeah,
hardly.
I've seen that.
Yeah, and I think no
I've seen
patient
that
much complains.
probably- Is it? I mean, I do not know. I have not seen you giving tab blocks.
Because I don't like it much actually. Why, if it's not necessary? This is what my. Then we see that every patient we see post-op, there is hardly any problem. Like this
Right.
patient also, we will not give an.
But
I
still,
don't
do you
know.
think? I mean, because I know Vikas sir and
Yeah, everybody likes love.
They
Yeah,
love
yeah.
tab blocks.
Yes.
even Arun
Yes.
sir loves it.
Yes. But is there any difference between post-op?
I have no idea. Sir.
Yeah, there is no much. That's what I feel so.
Okay.
So I personally feel that in anesthesia or anywhere in surgery or otherwise, whatever utterly important, that only I will like to do at. Yeah, that is what my take.
That is true.
Yeah, but everything has got some sort of a complication. No injection, nothing is. See, I will tell you an incident. I used to work with one of the very senior. He is no more there. One of the very senior ENT surgeon. In his nursing home, whenever I used to go, he used to tell that remove everything. So I asked, what are the if I remove everything, no injection can be given. But no injection can be given means actually sister can not do anything wrong. She cannot give a wrong injection. How you avoid the complication of any injection is not to give injection. Similar thing, how you avoid any complication of any procedure,
But
According to me, that is what, if I am a patient, I will be definitely happy with that.
there is some bleeding here, which is just.
Oh, the bleeder, there is a bleeder.
Nine. Section, please. Suction working? Okay, there is a clot. That's okay. Chhod do. Yeah, that is a very good method, Patil sir, but then I don't think patients will like all that, sir. I mean, not that patients
See,
know.
today only we did some stent removal that is under actually topical, means it's like
General local
putting
anesthesia.
local anesthesia, putting the jelly into the urethra.
Yeah,
Like the moment sister took syringe in her hand, she started screaming, "Oh, you are giving me injection." But no, we are not giving injection. It was just loaded with the lignocaine jelly and then we put. See, anybody is afraid of injection. We have seen a number of videos also on that. See, that's the reason whatever it is necessary should be done according to me. That is what my take always.
I want to tell everybody that I am cutting it with the laparoscopic shearer and it is on L3 right now. Okay, sometimes we have escalated from L3 and gone to L6, L7, but I don't think it is required in this case. I don't think so. It's fine. It's a very deep-seated intramural fibroid here, which is of course impinging on the endometrial cavity. So we need to remove it out. Here, this is the fibroid, this is the plane of the fibroid, to be honest, here, and it's very deep. So for a bulky uterus like this, it's known to happen. See this is where this is the plane of the fibroid, from where that entire entire tissue should come out. Now of course people can have an argument onto this, that how do we make the surgery faster. I personally think this is good speed, right? You should not aim for going faster than this in a case like this, where fallopian tubes and fertility and everything is to be preserved. No, you should not aim for anything like this. This is good, step by step. Really, trust me, there is no major bleeding so far anywhere. Whatever has happened has been controlled. Whatever will not be easily controlled on this will be sutured off. And as I have taught you, as far as the suturing is concerned, see, go layer by layer, perfectly removing from the capsule, and usually a large chunk of the tissue, the fibromatous tissue, a large chunk will come out, guys. See this. Also, I personally am of the opinion that usually when you have these types of fibroids, okay, it's good to go and take off a little capsule, just a little capsule from the aspect, so that the release of the tissue is good and it is easy. See, can you see here in the depth there are fibroids here, the extension is in the depth. So when there is an extension in the depth, just want to cut just beyond the capsule, so that you can release it out. Okay, this is good. छोड़ दो, यहाँ पे पकड़. I'll go little lateral, as I told you. I want to go little lateral there, more in that plane. See that you have fibroids here. She has multiple fibroids. साफ कर लो. There was a smudge on the camera. Let that get cleaned off fast. We will do 2-3 intraoperative ultrasounds just to see if we have missed out on any fibroid tissues. Posterior wall seems to be good to me. I am not suturing because I am yet to release off everything. See that there is a speck there which I have to release off. So okay, इधर आ जाओ. Careful, a large window, large part is coming off. I'll just go little underneath this, as I told you. See, when you have multimodal fibroids, multi-layer involvement and small ones, just go beyond that capsule a little. See that? Just beyond that capsule, it is all smudged there. Is all smudged in this plane. Gently I am just moving through that plane, which is good now. नहीं, मुझे पुराना शेरर ही दो. अभी जो तुमने मेरे हाथ में से लिया ना क्लीन करने को, उसको दे दो. No hurry, and trust me, do not hasten up anything in this window. Just knock it out. ये थोड़ा थिक है ना, ये थोड़ा जाड़ा है शेरर ये वाला. नहीं हिलना मत गोलू. It's going deep there. As I told you, you know, it is having a deep involvement here. Can you see that? That is the involvement of the mass. So here we go, going down in that plane gently. So often, you know, you will see me not using myoma screws like how it is in this case. That's the endometrium. So I have identified the region of the endometrium, and I do not use myoma screws, as you are aware. But no harm in using one, na? I mean, if in case you are somebody who likes to use myoma screws, okay. See, the problem about myoma screw is you need to like to use it, nahi? I am not so much, I don't like it only. So when I don't like it, na, then I don't prefer to use it, because I believe that I will be able to take out, see, if this is a fibroid, for example. So I believe that I will be able to do the myomectomy, I will sort of achieve it without using it, no. So this is just one of my inhibitions, ne? And I am not trying to say anything to that. This is just one of my inhibitions towards it. But as I told you, if somebody likes to use it, and somebody thinks that, you know, the control which they have over all these things is better, then they may choose to use it, yeah. See, it is all because I am cutting through that tissue planes, no? It's all. Good to go? What say Santoshi? Good to go? Thank you. Okay. So here we go. The component is coming out. Huge one. But see, it's so badly stuck there, nahi? See, the whole system is so bad. Okay, we need to be careful now. That's the endometrium, guys. So we need to be careful. You will have this little pilferaging spillage which will keep on occurring over the tissue. I mean over my camera from that point, which is fine. See this large tissue. So I think we've got, that's the endometrium. There is a fibroid here. It's a no-brainer that we have a fibroid here. See, sometimes these smaller ones you can't see in the shadow of those large ones, nahi? See this, for example, this one. This is a submucous fibroid. Let this be number 5. Mark and map, this is important. How many you removed? See, there is one more here. See this? So mark and remove. This is number 6. It's not even coming out easily, and it's not coming out easily because probably it is joined here. See this. We have a smudge on our camera which we will clean because my Alice is actually not holding on. See that? When the Alice does not hold on and give proper traction, you will get that smudge spillage which will keep on occurring, okay, over your camera. Now fortunately, despite that, there is no major problem in the vision. That is because this camera has a glass shield which is covering it, so through the glass you are still able to see. But for a direct camera which does not have a protective shield, you may encounter some problems, okay. Look at this, look at this. Nahi, unable to hold, that is the problem. Thank you, Golu. Oh, there is one more fibroid there. See that? Dikha? Ye dekho. Underneath. Hai na? But I think now a lot of it is out. आवाज आ रहा है संतोषी ठीक से? I do understand, guys, there is a little smudge on the camera, so you can't see it beautifully well. Just a minute before I actually clean it off. Here we go. Okay, done. It's a big part which has come off again. See, these huge ones have come. And for all these big ones which keep on coming, we need to be careful. Name them, number them, that is important. Transvaginal scan ready karo please. Good, not bad, not a major, no major blood loss from what it looks like. Idhar aa jao. But we literally want to make sure that's the endometrium, that's the cavity there. See that? That is the whole cavity, full cavity from all the sides. We have knocked out. चलो अंदर आ जाओ guys, इसको ऑन करो. Okay, so yeah, there is something. इधर आ जाओ, गोलू मत मत करो प्लीज. I think the entire cavity is okay. Most of the fibroids have been knocked out. Maybe there is one here. Okay, ऐसे पकड़ो. Yeah, maybe there is one here, is what I think. It's okay, we'll just see. No harm in just opening up the cavity and keeping from there. Maybe, okay, I'm not very sure of it. It seems to be very deep, and because now it is smudged with blood, unable to make sure if that is the one. But you know what we have done is we have kept the ultrasound on. So looking at that part of the cavity is going to become easy. It is too deep. Honestly, this is the plane, if at all it is present. In an otherwise situation, it could simply be an adenomyoma there, which is not rare, nahi? When you have so many multiple fibroids. इधर आ जाओ. See, I said, right? Maybe something is here. But it is a small one, huh? If at all. There is a fibroid, there is no question about it. this out. See that fibroid there? So with this fibroid now going out, as I told you, we will be very quickly begin. That's the top of the cavity. You have an endometrial, so it's a submucosal component of this entire myoma. So once this is out, we will start suturing. So can I have 45 please, girls? Girls, ready? Thank you. Can you see that? That is the endometrium. See that component inside there? That is that submucosal component there. That is where I am entering out of the cavity. So we have to be careful. Huh? That was number 7, and this is the final one, the tiny one inside. Look at this. Careful, huh? We should remove these guys also. Never keep. This is the one which will cause the maximum pain and maximum headache and maximum bleeding by this tiny guy. So here we go. Okay. Everything is out. Sutures. Now everything is out. Yeah, I am very confident that everything is out. We will begin the sutures. De do. Thank you. 45. Not much bleeding. See that? But the suturing will be super fast from here on, because usually whenever I am trying to suture, I will suture the back first and the front later. Always I like to suture the posterior wall to start off with. Again, as I said, everybody can have their own opinion as to how they would want to do a particular suturing. This is what I prefer, and which is why I am going to be showing you what I prefer. Okay. My instrument will move through the tissue planes, and it will actually move through the tissue planes very fast, because that is how I am used to suturing. I am used to suturing. Chhod do usko golu. Despite having a large uterus, I am used to suturing in the depth. So the minute I hit the depth of the cavity, see that is the depth of the cavity there, I will literally go in the depth, and I will not take it as a single layer. This layer is going to be a dual layer or a triple layer, but mostly a dual layer suturing technique, which I will try and show. The apex is done. Just reverse everything. See, for a large 45 centimeter, this is the thing. Use excellent needle holders. That is my first thing to you. I see people using absolutely archaic needle holders when they do surgery, saying कि बस हमारे पास में ये ही available है. Never compromise on the needle holders. It is something which will change your suturing skills permanently. So use excellent needle holders. Use excellent needles. Use excellent suture drivers for such type of situations, because remember, the more you become an expert, only this you will see. You will not get to see a solitary 2 centimeter fibroid. We would say to the patient that a 2 centimeter fibroid, follow up, and somebody will remove, right? So if you are interested to up your game and go from this 2 centimeter window and hit a window where you are comfortably just suturing off everything. Just see this. Then you need to up your suturing skills, yeah. And the best way to do suturing skills is as we had taught in the Project Pelvis conference, and that is to practice on the pelvic triangles. If you are looking at my hand movements, I have no hand movements, yeah. See that? My fingers are the ones who are rotating the axis from one rotational angle to the other rotational angle. So here we go, full bed I have sutured off. See that? Bed is gone, yeah. Suction कर लो bed पे. No major bleeding. See that? See, it's so good. Now I want to highlight one important thing here. Often we are worried about having assistants, and array, if I don't get an assistant, what I will do. Look at how Golu is assisting. Okay, this is what you have to learn in your private practice to develop a technique where anybody, any of your staff becomes so well trained that they can assist you in any surgery which you want, right? If you are able to do that, and if you are able to get through the initial deficiencies of that phase, that when a staff is assisting you initially, they may or may not, they may or may not be able to assist you at the level at which you are expecting them to assist, correct, no? Then you will completely take out, like this is like a laparoscopic surgery done with robotic precision, because here whomsoever is assisting you, if your technique is standardized, 15 centimeters चाहिए, if your technique is standardized, then it simply 30 भी चलेगा, then it simply doesn't matter. So what's going to happen here is that as soon as I finish this, Visma is going to come in and he is going to be starting the morcellation, which is also going to be shown by him live. And once we show you the morcellation live, you will have some take home points. It is going to be a morcellation without the usage of a MorSafe bag, just making that clear. So now see, you have a gap here, nahi? This gap is something which I don't like, so I am going to be using 15, इसको cut कर दो, 15 centimeter, नहीं 15 चलेगा, sorry, एक needle out, 15, we'll use 15 and then we will use one more 15 and we'll close it off. Suction. So here we go. It's just a superficial rim here. छोड़ दो. One suture below that, one suture above that. Oh, that's a, see that little suture broke there. That's okay, we'll tie it, we'll knot it out. See, this is why we knot, it must have broken because one of the windows must have got too stretched, so that can happen. There is no panic button in all this, yeah, just tie it off. Once you tie, nothing will happen. इसको यहाँ पे कट करो. Thank you. So I'll be tying the two ends. Here you go. Oh, this is good that it happened here. You know, you can see how you will manage all of this on the, you know, on the spot. ऊपर खींच लो. Step. नहीं, non tooth needle holder लो. See that? Just tying it off. उसके बाद में और एक 15 लगेगा. नॉन टूथ चाहिए था उधर, और दूसरा नहीं है. ठीक है, चलो चलो चलो, टूथ से स्टेप कर लो. गुड. या, थैंक यू. एक्सीलेंट, एब्सोल्युटली एक्सीलेंट. वेट, रिलीज. डन. नो नीड टू इवन कट. दिस इज डन. चलो 15. नहीं चलेगा, लूज हो गया. ओहो, गुड वन. शी टोल्ड मी दैट इट इज गॉट लूज. वेरी नाइस. छोड़ो, खोल दो आप. नाउ इट इज देयर. और एक बार स्टेप कर लो, मैं और एक ले ही लेता हूँ. गोलू हैज टोल्ड मी दैट टेक वन मोर ओवर दिस. यूजुअली आई विल, बिकॉज okay, leave 3 stitches. Yeah, now no need to loosen it. 15 de do. This 15 will take care of the posterior part first, and then I need 45 for the front. Hey, 45? Give me 45 for the front. This is that posterior margin which got cut by me when I was removing that fibroid. So nothing, just suture it off. Fallopian tube is intact, no problem. And this is it. So this much is enough for this region. I will just cross it over. There is a small hole which of course I will suture. That actually, that bleeding is coming from the front and it is nothing to do with this, but you know, I am still going to suture it off. There is a mouth which is opened up. and it will get entangled in this, so no problem. Correct. So this is done. Suture it off. Scissor de do. Come. Lamba kato. 45 please. And we go on to the anterior. વિસ્મય ઓલીનું એન્ડો મેપિંગમાં કઈ છે ક્લીન છે એક પેશન્ટને મોકલાવેલી સિરોયા સ્લાઇડિંગ સાઇન નેગેટિવ પોઝિટિવ નોર્મલ છે રાઈટ બિકોઝ આપણે એને લાસ્ટ ટાઈમ એનું એમઆરઆઈ વાંચીને કીધેલું ઇટ ઇઝ નોર્મલ સો ધીસ ડેઝ વી હેવ ગર્લ્સ કમિંગ ઇન યુ નો દેર इज 5 मिनट के बाद देखेंगे सर मुझे बात भी करना है उनके साथ हाँ
इसलिए तो मैं वही
हाँ हाँ
अश्विनी को ओपीडी में बिठाना है कि
हाँ
नहीं बिठाना है
नहीं मैं बात करेगा
वहाँ
उधर
पर ध्यान में रखना
हाँ नाउ worry is just this as I said before once I suture off everything behind I will come ahead and see this. The problem is this. You can see a submucous fibroid which I am going to remove laparoscopically. Please don't miss out on these fibroids, my request. It is the same which would have happened even in hysteroscopy. You would have taken out and the submucosal plane would have opened up, but you should not miss out on them. See this, like this. Like I am sure that this is a fibroid. I am sure. मुझे Alice दे दो. I am sure that that is a fibroid, isn't it? And when I am sure about it, I don't want to miss out on that, yaar, because that, see this, that if we miss, then it is not good. See, this if we miss, it is not good. Let it go down. All of that is going in the cervix. Saw that? I have opened the cervix as well. No tension. Fine. This is good. Okay. Come, sutures. It is good. It is good. No problem. I am happy. I have opened up the cervix, so I am not worried about the cervix as well. She will become pregnant also. No tension. Now this is one of those cases where now if we wish, because the marginal things are so good, we may attempt to also do a colpotomy. Yeah, I am using Alice. I can attempt to do a colpotomy here, and when I do a colpotomy, all the fibroids I can take out through the colpotomy and save the time for doing morcellation, nahi? Because otherwise morcellation will take 1 hour here. Two layered or single layered, I do not know, I am yet to decide. Considering the way in which this is, I think a single layer should be enough as long as it is getting closed off nicely. Let me see, there is no much depth here, I just have to go in that little depth for me to close it. I just want to see that. Yeah, I think single layer should be good. Let me see if I can invert these layers. Should be a good closure, I think. But the colpotomy will be a big one, huh? Because it will be like a vertical colpotomy for us to remove so much specimen. We will just explore that possibility. If it is a vertical colpotomy, all the specimen will come out like super fast. That much I am sure. Okay, the speed at which the specimen extraction occurs, it's a great time saver, huh? It is, of course, if we want to save time. For a OT list like ours, we have to save time, isn't it? छोड़ दो. Sometimes we may feel that, you know, it is will we actually do any great benefit by doing this type of suturing to the patient? But believe me, now I think, of course, I don't want to speak all this because I think this is not published, but then yeah, it's okay only. I don't want to speak. This is okay, there is nothing there. Now we have to pray to God that, you know, this girl, see this, how beautifully it has closed. See, we have, it was of course my horizontal incision only, so we have to pray to God that this girl does not require any form of future myomectomies, because see, she is already having adenomyosis, huh? So now from here onwards, whatever she requires, no, is going to be dangerous. It's no longer a simplified surgery for her, it is complicated from here onwards. See this? So here we go. Last two sutures. पीछे आ जाओ गोलू. See the stability of Golu's hands there. No movement in the hand. You often see junior students who are trying to learn endoscopic surgery will move their hand 150 times in a window like this, you know, per second. It makes life difficult for the operating surgeon in that case. Here I am going blind from one end to the other end because I know that whatever I am doing, it is happening in the correct plane because Golu has not moved the instruments at all. This is what you have to achieve, you know. So this is the end here. As we come to the end of the suturing, I want to make an assessment if I can actually do a colpotomy here. क्या लगता है गोलू? According to Golu, no. According to Praveen, according to Patil sir, it is colpotomy. So let us see. Chalo, scissor. Bas. Okay, let's see. Now let's see. Uterus seems to be very, very good. So I want suction to me. I want Golu to use a instrument. Fallopian tubes are damn good, guys. Let's see if I can explore a colpotomy here. If this is here and suction कर लो माउशी. प्रेशर बढ़ा सकते हो. Okay. No bleeding, huh? Maybe 200 ml. Isn't it, Patil sir? I'm just suctioning it off. I'm not happy with the suction, the way in which it is, but there is a clot. And I think see, I think we can take a gamble of attempting a vertical colpotomy here. Okay, if we do that, the specimen will be out in no time. So we have two big specimens and let's see. Come, मैं यहाँ पे ये दे दो instrument, POD में डालो. So primarily in your vertical colpotomies you need to be careful about 2-3 things. Yeah, first is let this guys go behind. Yeah, great. That is what. अभी निकालो एक सेकंड, थोड़ा सा रिलैक्स करके एंटीवर्ट करो, एंटीवर्ट करो, रिलैक्स करो, एंटीवर्ट करो. ग्रेट. गोलू अंदर आ जाओ. नाउ सी दिस. फर्स्ट सेपरेट द बावेल. या फर्स्ट you got to separate this bowel nicely. Huh? No half-heartedness in this. आगे आ जाओ गोलू थोड़ा. So here we go. Posterior vagina and bowel are now two different organs. Okay, primary achievement is done. Primarily we have achieved that. Now once you achieve that, just loosen this all. You need tissue to be loose, so just loosen, just separate all of that flimsy fibers there, which is okay now. Now andar aao. Correct. So now when they come inside here, see this. It should start from this point. Here we start. This is the curve of the uterosacral. So exactly on that curve we start. Beautiful. Extend it along the curve of the uterosacral. Look at this. Along the curve, along the curve, along the curve. Now, after having extended it like this, you have two options. Through this plane, you can make a smiley there. See that? That's a smiley. Another smiley, another smiley. This little part is the vaginal region. So just extending it. Now it looks to be good here. छोड़ दो. Specimen number 1 अंदर डाल दो. इधर आ जाओ, आगे आ जाओ, आगे आ जाओ. Number 2, you have number 3, you have number 4. बराबर? आगे 4 थे. Okay. So now what is going to be important is how Golu holds here, which he is doing good. Let me नहीं गिरेगा, रुको रुको. Gentle. This is exactly how we want her to hold. Let the ovary and the fallopian tube be requested to be on one side temporarily. Okay, temporary request to both of them. If they listen, it's a different story. So 1, number 2, number 3, number 4. 4 big specimens are out. Number 5. Now, this is a big one. Number 6. छोड़ दो गोलू. So now we are losing out on a lot of gas there. पीछे आ जाओ. This. हाँ, okay. तो इतना ही है. और 5 है. छोड़ दो. और 4 है. Okay. So this much is done. Let me just one by one slowly go. I did see a small one there. सक्शन दे दो मेरे को ये हाथ में. See that? I saw that. छोड़ दो, इसको पकड़ो, ये साइड आ जाओ. छोड़ो. So that is one. I'll just push it down in that plane. Is there one more? है और एक ऐसा. Let this be there. Let this go here. And this is that fourth one, correct? Now, of course, we have identified. Let the big ones be wherever they are, there is no problem in that. Alice. And you can see that is the culpotomy. Number 7, number 8, big ones have gone. This is one big one lying down here, which I will just put here. Okay. Yes. Now, I will come in with a large claw. Upper part it comes, it grasps, and it can rotate. Now, when it rotates, usually it will get the specimen out. So, big one coming out, which has come out. Praveen, you can show the specimen which has come out. हाँ दिखा. And here you go. You have one more, which is there, which we have to remove. It's a large one again, but we will try to remove it. Nulli parents, huh? Newly married. You can see the advantage. Yeah, I have held it nicely. I just want to make sure. Yeah, I have held it. Now, Once I hold it, I will actually go to the vagina now, because this is a large specimen, and I will try and incise and take it out. So when I incise and take it out, the great advantage is, light de do, there is no damage. Gas off kar lo. Of course guys, unfortunately this is the part which we can't show you, but yeah, it's okay. See, the specimen is out through that, through the vagina. If you can see, this is the large specimen coming out through the vagina. The advantage of doing a Smiley colpotomy 15 is that the time which we took for doing all of this was probably 10 minutes, isn't it? And in a 10-minute window, we can knock out everything. Just thought I'll show this to you. As I told you, I am mighty impressed with the girl. We'll take a Insta with the specimens. White phone leke aao. So all I'm now going to be doing is closing off the Smiley colpotomy which we just now did for this girl. Gas please. Yeah. We'll close the gas, by the way. No, it's okay. So of course, the worry in Smiley colpotomy, let's criticize the Smiley colpotomy that the fallopian tube can go and get stuck. Guys, no problem. Just do it nicely. Nothing will go and get stuck anywhere. It's okay. This is bound to happen. See that the uterus will wobble. Why does the uterus wobble? Because we are just pushing it. Yeah, and there is very little space there. So in that little space, when you push the uterus, andar aa jao, maybe this point is where you may feel that it would have been better if the Smiley colpotomy would have been done robotically so that we can reach to the depth of the tissue. Now I personally do not think so, because I think this depth is a little negotiatory depth which is very tough to achieve. No, the thing is, see how did it get dislodged. So the thing is, you got to hold and lift it up. Yeah, when you hold and lift it up, usually the dislodgement does not occur, but of course nobody's fault. The space inside is really limited. So here we go. This angle has been taken in and the fallopian tube has gone out. Yeah, once you do this, see that fallopian tube loves to come there. Praveen has done an excellent thing. He has kept a menstrual cup in the vagina, correct na? So there is going to be no leaking of gas at all. Suddenly the field from a tough field, see this, has become such a fast field. Quick thinking is advantageous in a situation like this. Do we need to close that? I think no, it's fine. The closure has been achieved. Yeah, scissor. So guys, thank you so much. Bye bye. Take care. I hope you really enjoyed watching this entire thing unedited, uncut. Hopefully it will give you a lot of good insights. Bye bye. Take care.